This is Radio Health Journal. I'm Reed Pence. This week, improving treatment for perinatal depression.
OBGYNs historically did not get any training in psychiatry, and a lot of women survivors will describe really having felt abandoned or in a place where they felt like nobody wanted to care for them.
How that's changing when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
We will come out stronger, smarter, and with some new ways of doing things.
Finding the silver lining during these trying times. Then,
I'm like the pillars of appropriateness. How did I get there? This is how. But I also wanted to explain myself to my kids at the same time.
The Life Lessons of actress Drew Barrymore. I'm Marty Peterson.
and I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
A couple of years ago, new mom Jessica Porton of Sacramento, California, packed up her then 4-month-old daughter and headed to a doctor's appointment. It was her first appointment with her OBGYN since giving birth in the fall, and Jessica had several things she wanted to talk about, including what she recognized as depression.
I told them I was irritable, I was angry, I was having intrusive, violent thoughts, and I believe I had mentioned that I was not sleeping well.
Jessica didn't think it was a big deal. She just needed a little help.
I thought that they would refer me to a psychiatrist or a therapist. I thought that they might actually help me schedule that appointment. And I thought that they might prescribe me medication like an antidepressant. Or if they didn't, they would at least refer me to a doctor that could.
That didn't happen. Jessica was seen by a nurse practitioner first.
She asked me, when you have these, what you're calling intrusive, violent thoughts, do you have plans? And I said yes. And so for her, that meant that I was planning on hurting somebody. And for me, I thought that question meant, do you have specific violent thoughts? I remember thinking to myself that that was a really, silly question, that people don't have vague violent thoughts. They think about specific actions.
Jessica says that was enough for the nurse practitioner to establish intent to harm, so the office called the police. They escorted Jessica to the emergency room, where after 8 hours, she was finally seen by a physician's assistant.
She was very thorough. She asked me a lot of questions about my support system at home. She asked me a lot of questions about whether I had any suicidal ideation. She asked me to go into detail about the specific violent thoughts that I had. At that time, I felt like I had to lie or they would remove me from my child and institutionalize me. And really my goal was just get out of there. Afterwards, she did review paperwork with me that had phone numbers of resources here in the community, but I was just baffled. They did the best that they could, but did I get any real tangible help? No, not by any means. In fact, I walked out of that emergency room a lot worse off than when I walked into my doctor's appointment that day.
When Jessica shared her experience on Facebook, it generated tens of thousands of comments, with more than a few women saying that just about the same thing had happened to them. And it triggered outrage that someone with such an exceptionally common problem would be subject to police action when all she wanted was some help.
The idea that somebody who's expressing distress and has concerns about mental health would be taken by the police to the emergency room just seemed like such an extreme reaction on the part of the OBGYN's office.
That's Dr. Darby Saxby, Associate Professor of Psychology at the University of Southern California, who has studied perinatal depression.
She didn't leave with a treatment plan. She didn't see a psychiatrist. She didn't connect with a talk therapist. So despite how awful the experience was for her, none of the problems that she originally expressed got solved. So not only did it feel like she was being punished and treated like a criminal for having symptoms of depression, but the entire experience was just so ineffective.
However, Saxby doesn't think the nurse practitioner was entirely in the wrong. Her response might have been disproportionate to the actual threat, but the perception of threat is actually more important at that point. If the nurse practitioner felt Jessica might be a risk to herself or her child, she had a legal and ethical responsibility to protect.
What the nurse was trying to do makes sense in the sense that as mental health professionals, we get a lot of training in risk and wanting to avoid risky situations. And if somebody's a danger to themselves or to someone else, it's important to intervene swiftly. And so I think the reason the nurse wanted Jessica to go to the emergency room is because she wanted to avoid the risk of harm coming to the infant. But in this case, Jessica really was expressing some common symptoms and just needed some more assessment to determine the extent to which she posed a risk to her infant.
When I heard of that case, my heart really went out in both directions. One, as the person who was trying to advocate and educate providers on maternal mental health, I thought, that response was really disproportionate to the situation. On the other side, as thinking about me being a provider with a woman in front of me, I think, at the end of the day, I just want to keep everybody safe.
That's Dr. Tiffany Moore-Simas, professor of obstetrics and gynecology at the University of Massachusetts Medical School. She's also been co-chair of the American College of Obstetrics and Gynecology Maternal Mental Health Expert Work Group.
Physicians, of course, are criticized for overreacting when a mom is less ill than they thought and their response was disproportionate. On the other hand, there would be significant criticism if a mom was sent home and there came harm to her own life or that of her infant. And if you're going to err on one side or the other, it's understandable to, see why the error may be on the side of overreacting in safety than underreacting.
Doctors have come to realize the importance of postpartum depression the last couple of decades. But these days, it has a different name. Now doctors call it perinatal depression because 60% of the time, depression starts earlier than postpartum, either during pregnancy or before a woman even gets pregnant. But whenever it happens, it's very common.
Perinatal depression, including both major and minor depression, affects about 1 in 7 women. That's general population across the board, research and statistics, but some populations really have much higher rates. So if we look at adolescents, women veterans, women who are socioeconomically disadvantaged, the rates can be as high as 1 in 3. And there are some studies that even go 50%, which is really high. It's very common.
Moore-Simas says the symptoms of perinatal depression are the same as at any other time. A long list including sadness, emptiness, irritability, loss of interest or pleasure, insomnia, worthlessness, fatigue, changes in appetite or weight, and recurrent thoughts of death or suicide. But she says pregnancy makes doing something about it less likely. Patients like Jessica, who know they're depressed, are rare, so accurate screening is important.
We expect some changes in things like sleep, appetite, libido, for example, that people will often attribute to normal pregnancy and postpartum changes. So if you say, your sleep is disrupted, you're having trouble sleeping, you're getting too much sleep, that's normal, then you are potentially dismissing what is a symptom of depression for this woman. And the fact of the matter is that less than 20% of women will report symptoms or voluntarily report symptoms to the healthcare provider, which is why there's really a focus on screening women using a validated tool.
Postpartum depression and anxiety are massively undertreated. And I think part of that has to do with the way we stigmatize mental health problems. So, these women are concerned that if they report symptoms of sadness or symptoms of anxiety, that, that's not sort of what the new mom is supposed to feel like. We have this cultural norm that when you have a new baby, you should be spending all your time gazing at the baby, just feeling completely blissful. And if new moms aren't feeling that way, they might be really uncomfortable expressing that or asking for help. So anybody that's working with pregnant women or with women in the early postpartum period should be trained in how to assess mental health problems.
The kind of thoughts Jessica was having, violent, intrusive ones, prompting fears of imminent harm, are also common. That's another reason OBGYNs need to be adept at screening.
These intrusive or violent thoughts, if women were really being honest with themselves and, ourselves as both a, provider and, a woman who had babies there, it's very common and they can be incredibly scary. They're, often negative. They can be repetitive and certainly unwanted, and they can come on for a woman at any time, but they can also be exacerbated or triggered by things. A woman who walks by a staircase and suddenly has this intrusive thought about throwing herself or the baby down the stairs, or as they're bathing the baby, worrying about burning the baby or drowning the baby. And these are often thoughts that are very bothersome. They're very distressing. They're very much unwelcomed and unwanted. And those are thoughts that a woman in some ways can be reassured about if it's what we call ego dystonic, meaning they're distressed by them, they're repugnant, they're unacceptable. Then those are the ones that are a little bit less concerning.
But if a new mom is having those thoughts and they don't distress her, Moore Simas says that's a red flag.
The woman has poor insight. They can be associated with psychotic symptoms or delusional beliefs, or she thinks that's the right thing to do, that maybe that she would be saving the baby from a lifetime of hurt. Those are the ones that are far more concerning. A common visual, because often these thoughts come with very scary visuals for women, is a woman who's in the kitchen next to knives and thinks about stabbing her belly if she's pregnant, or the baby. I think it's important for women to know that these are more common than we necessarily think.
However, even though mental health issues are, according to some, the number one complication in the postpartum period, that doesn't guarantee that it's treated.
OBGYNs historically did not get any training in psychiatry. So when you were pregnant or lactating, where did you go? And a lot of women survivors will describe really having felt abandoned or in a place where they felt like nobody wanted to care for them.
Moore Simas says training is improving dramatically, but many OBGYNs are still relatively uncomfortable treating perinatal depression themselves and have to refer patients to a mental health professional.
We're talking generations of providers here. I can tell you I trained in the late 90s, early 2000s, and I personally, to my recollection, received little to no training outside of, the medical school class and rotation in psychiatry. Specifically as an OBGYN, I did not receive training as it related to maternal mental health. Now, you think about that and say, well, if it's one of the most common complications of pregnancy, how is that possible? We're coming to realize that. Now, the generation of OBs that are about to, springboard out into care will have a much greater comfort level than those that trained in my era or those before me.
She says either treating in-house or referring out, doctors should have systems in place to follow up and manage the condition. Some OBGYNs have ready access to mental health professionals on the phone. Others have them right down the hall as part of their practice, and Saxby says that's proven to work well.
When we look at the models that have done this, and not just in the postpartum period, but across the lifespan, when there's mental health care that's available within the same practice that people go to get their routine medical checkup, when we look at the outcomes, people actually end up having not only better mental health outcomes, but also better physical health outcomes. So we really need to make mental health care more accessible and more easy to connect to, so that when you're seeing your OBGYN, that OBGYN can immediately refer you and get you into the system to get seen by a mental health practitioner if that's what you need.
However, a shortage of mental health professionals and a lack of parity in payment for mental health treatment have made those kind of moves difficult. Moore Simas says insurers also typically pay OBGYNs as a per-patient bundle, a rate that doesn't change even if the doctor adds valuable services like mental health treatment. OBGYNs are increasingly making it an important part of practice because, as Moore Simas says, if we don't take care of the moms who take care of our newborns, what does that say about our priorities? I'm Reed Pence.
Most primary care doctors expect to see more people with dementia over the next 5 years, but a new survey shows half of them don't think the medical profession is ready. Primary care physicians are on the front lines of dementia care, but nearly a third are never or only sometimes comfortable answering patient questions about it. Nearly 2 in 5 say they're never or only sometimes comfortable making a diagnosis. That's deeply concerning to Dr. Joanne Pike, Chief Program Officer of the Alzheimer's Association.
We're heading toward a medical emergency when it comes to ensuring dementia care will be available for all who need it. It's critical that stakeholders work together to reverse the shortage of dementia care specialists and enhance dementia care education for primary care providers.
The survey is part of the Alzheimer's Association 2020 Alzheimer's Disease Facts and Figures Report, which finds that, barring medical breakthroughs, the number of people with Alzheimer's dementia may nearly triple in the next 30 years. Find out more at alz.org. With the threat of coronavirus, social distancing has become the new normal. But staying safe presents unique challenges for more than 5 million Americans living with Alzheimer's and more than 16 million family members and friends serving as caregivers.
Public health strategies aimed at limiting contact with others are nearly impossible for people living with Alzheimer's who rely on family caregivers and others every day.
Beth Kallmeyer is Vice President, Care and Support at the Alzheimer's Association.
For example, people living with Alzheimer's may forget to wash their hands or follow other safety precautions. Family caregivers need to be extra vigilant in helping individuals practice good hygiene.
Alzheimer's families also need to anticipate that current care, support, and communication options may change and make backup plans. And try your best to stay calm. People living with dementia take their cues from those around them. The Alzheimer's Association has more tips at alz.org, or caregivers can call its 24/7 helpline 800-272-3900.
And that's Radio Health Journal for this week. Radio Health Journal is a production of MediaTrax Communications. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.